All right. Well, I think we're ready to go. I'm sure some people will be filtering into the room as they go, but we've started recording, just so you know.
Yeah.
Well, so welcome, Martin. Thank you very much for sharing your time and experience and knowledge with us. It'd be good to, I guess, have you share a little bit about you first and what your experience is, where you study and where you research and all those sorts of things.
Of course. Yes, and thank you for the opportunity, which I grabbed at when you contacted me a couple of months ago, because, like I just said to you, Marianne, I'm quite keen on also getting reactions to what we do from people. So it's good to be here from Denmark. Do you hear me? Good. You all hear me good. It's good. I'm Danish, but I do my PhD research in Germany at the University of Marburg, where they have quite a good tradition with tinnitus studies. So I decided to get my things, pack them in my car, and go down there and spend 3 years. But now I'm back here in Denmark, where I'm currently finishing up writing this study of ours. And I think I will just try now to put on this. If I can share my screen there. One of the first things that I just wanted to mention about this study is that it's kind of a collaboration between the Eriksholm Research Center, which is where I'm actually employed here in Denmark. The Eriksholm Research Center is part of Oticon, it's a hearing aid company. And as I said, I'm doing I'm registered as a PhD student at the University of Marburg. So I have a Danish employer, but registered in Germany, doing this PhD. And importantly, the funding, just to say, where does the funding come from? That basically comes from the Demand Foundation, which owns Oticon. So, but although it's funded the study, the Demand Foundation has no interest or commercial interest in it. Basically, they've given a sum of money and said, do with it what you want, basically. So no commercial interest or conflicts of interest. Now, I cannot do this and have not done this on my own. Mainly, I have worked with 2 people and a bunch of students in this project, but here we see my supervisor, Dr. Cornelia Weise, pointing to the screen there, showing me how to do neurofeedback. And behind me is my fellow PhD student, Eva Hüttenrauch. And as I said, we probably had around 10 students helping us over the course of the 3 years in which they've done their dissertation work or been employed as student assistants. But let's turn to today's menu. I've kind of tried to divide it into 4 sections because I didn't know how many people here knew about tinnitus specifically. I thought I'd just give a brief introduction to that. Then, as a second step, talk about the rationale for our study. That is basically talking about the background, what came before us, and why did we develop our study protocol and our research the way we did. Then I will introduce our study and basically show you what was involved in it, and also importantly some of the results. And then we finish off with some questions and answers. Now, I was thinking about this format, and maybe it's best that if you have comments, which I hope you have, ideas, suggestions, criticism, write them down and we will talk about them towards the end. We should manage to do this in 1.5 hours total, time. So yeah, just jot down your thoughts, and I am very happy to hear them at the end, because that's also one of the reasons why we are doing this. Right, let's turn to the first section, which is on tinnitus. And well, most people are probably familiar with at least the word tinnitus, but basically we call tinnitus the phantom percept. And that is because tinnitus is basically a sound that is perceived in the head or in the ears, where you have no physical source originating for it. So basically it's only heard by the person who has tinnitus, and you can't put some device in the ear for this kind of tinnitus that we investigate anyway. There are also some forms of tinnitus that are called objective tinnitus. That can be where, for example, someone has a mechanical problem in the ear, maybe with a problem with bone conduction, and that can actually be heard by someone else. But the kind of tinnitus we talk about here is the tinnitus that can only be heard by the person with no physical source causing it. When we talk about how prevalent tinnitus is, this kind of tinnitus is actually rather prevalent. When you look at or define it as a percept that's lasting for more than 5 minutes, or has lasted for more than 5 minutes, up to 30% of the general population say, yeah, I've definitely experienced that. And there isn't a lot of variation when prevalence studies are done across cultures and countries. So rather a common symptom, I would say, tinnitus. Now, the cause of tinnitus is not fully understood, but what we do know is that when sound processing is abrupted somewhere in the auditory pathway, it causes an imbalance in the excitatory and inhibitory neuronal activity anywhere along the auditory path, which ultimately leads to a synchronization, spontaneous synchronization of groups of cells in the auditory cortex, which is then heard as tinnitus. As I said, it's not fully understood, and there are probably multiple ways in which this spontaneous activity can occur. And if we look at some of the risk factors for developing tinnitus, there are quite a few, which also makes it a baffling condition to treat. There is no easily identifiable source, but the main risk factors are hearing loss. And those of you that work with people with tinnitus and ask them when did it start or how did it start, you will also find that many of them will say, well, it actually started when I had a period of stress in my life. So this seems to be also in my experience a rather common occurrence, that people say, well, I was stressed at the time when I started noticing tinnitus. So just to sum up, very common symptom, tinnitus. There will not be, at least in the foreseeable future, a magic bullet treatment, because we have probably multiple, as you saw, risk factors contributing or that can cause tinnitus, and therefore there's not going to be this little blue pill that I can take, swallow, and then everyone will be cured of it. So you're not going to die from having tinnitus, and therefore why does it matter, you could say. You have more life-threatening conditions, and with so many people having it, and maybe only a few complaining about it, what's the big deal? Question mark. Well, the deal is tinnitus can become quite distressing, and I do not want to entertain you with my own story, but I was going to say, of course, I have tinnitus, and I've had it for 10 years myself. And initially, and for the first few years, it was a bit of an ordeal for me. So I personally experienced it from the inside, what it means when tinnitus becomes troubling. For most people, however, unfortunately, most people habituate, as we call it, to tinnitus. That means you basically build up a tolerance towards the sound, and you are capable, or you manage to push it into the background, so it almost becomes like when you have the hum of the fridge. You don't notice it unless you pay attention to it. And I'm just going to have a sip of coffee. It's morning here in Denmark. So as I said, most people, they manage to live with tinnitus, slight nuisance, but no more than that. If someone says, do you have tinnitus? I say, yeah. Yes, I can actually hear it when I pay attention to it. But people can develop tinnitus intolerance. And you develop tinnitus intolerance when you attach emotional significance to the sound. When somehow the emotions get linked with the sound percept, you get a distress response. And that can be quite traumatic, and because suddenly that's all you can pay attention to, and start thinking that if I didn't have tinnitus, my life would be better, or I can't live with tinnitus, I can't enjoy silence anymore. So it can lead to anxious thoughts, to depression, and in worst case scenarios, very, very, very worst case scenarios, people contemplate, of course, suicide. Not of course, but they contemplate suicide. So yes, it's something that we should take seriously. Out of the general population, an estimated 3% would consider their tinnitus to have at least a moderate impact on the quality of their lives. So that is still quite a large number of people for whom tinnitus is a significant problem. Now, what do people experience? What areas of life are affected? And you could also say what areas of life are not affected. I'm not going to go through this list. It's just basically to show you that it affects quite a variety of domains in life. And I'll just let you look at this slide for a minute. No person will probably experience all these symptoms at once, but will have some of them that are more predominant. For example, problems sleeping, or problems relaxing, or someone will have more problems with the attentional focus, cloudy mind, etc. So it's an exhaustive list, as I said, but the question then becomes, well, if around 10 to 30% experience tinnitus, a subgroup of these experience it as distressing, why do some get distressed by the tinnitus? And that would be a lecture on its own to talk about personality factors and traits and factors that contribute to distress. But I just wanted to mention a couple of the personality traits that have been associated with tinnitus distress, i.e. Risk factors that some will become distressed by the tinnitus. There is this type D personality, the worrying type, the person with this pessimistic outlook in life. When someone with a type D personality, mind you, I have tinnitus myself, so I can talk about this. There is a tendency that we get preoccupied with it, have a lot of negativity around it, and have a lot of worry about it and problems letting go. Another trait is perfectionism. So if everything in life has to be perfect, having this sound in your head is definitely not perfect, and therefore it can be intolerable. Someone who thinks that events in their lives are outside of their control, we all know that many events happening in life, current situation not excluded with Corona, are outside our influence. But basically, for example, if you have an illness, there are two ways to approach it. One is to say, I'm going to take charge. I'm going to be responsible for my own health here. I'm going to do what I can to control my symptoms. That is someone who has an internal locus of control. That is, I believe I can control my destiny. Whereas someone with an external locus of control will probably have a tendency to say, well, there's really nothing much I can do about it. It's outside my influence. So therefore, they might engage less in coping mechanisms. Turning to, well, the second section of this presentation is the neurofeedback in the treatment of tinnitus. First of all, we should just say that the current state of affairs is that if someone goes to a doctor or GP today and complains about tinnitus, they will be sent to the audiologist, probably the ENT, for a checkup, be told there's nothing that can be done about it, and then, at least here in Denmark, you'll be referred to psychological treatment. And that makes sense because basically, as Coles and Hallam said back in the days, that it is not the tinnitus per se that is the problem. It is the suffering is mainly dependent on psychological factors. So therefore, these are also the ones that we have to address in treatment. So cognitive behavioral therapy, tinnitus retraining therapy are therapies that aim at reducing the emotional response to tinnitus and also, of course, the behavioral aspects of it. But the problem is, if you ask people with tinnitus, many of us, we don't want a psychological treatment because we want something that can take away the sound in our heads. And therefore, there is an interest in these neuromodulation techniques because tinnitus is a condition in the brain. It's originating in the brain, and therefore, if we want or hope or aspire to find a cure, it must be a brain-based treatment. And therefore, neurofeedback has become one viable candidate for that. So let's turn to the background for the neurofeedback treatment. Well, first of all, the treatment protocol that we use and other studies use are based on a discovery that was made in 2005 by Nathan Weiss and colleagues in Switzerland. Basically, what they found was a neuronal signature or a neural signature of tinnitus. What they found was that people with tinnitus compared to controls had enhanced delta activity, seen here as the I don't know what you call it. What do you call it in English? Is this line right? So they had a peak here that was significantly higher than the peak for the control group. So enhanced delta and reduced alpha activity over the both temporal cortices. So this was, as I said, dubbed the neuronal signature of tinnitus, that is enhanced delta, reduced alpha activity over the temporal cortices. So basically this led to the neurofeedback treatments that we're going to talk about now. The problem with tinnitus is that it is, as I said, it originates in the auditory cortex. The auditory cortex is, let me just show you now, is enveloped here in the Sylvian fissure. So that means those of you that are familiar with neurofeedback will know that you can't put an electrode on the skull and then register auditory cortex activity directly. You'll have to try to, do you say circumvent that? I hope some way, therefore in the treatment of tinnitus with neurofeedback, electrodes in the protocols that we used and the studies before us used were placed on the frontal central sides of the skull, because you could say that the auditory signal travels from the auditory cortex to the frontal central region via the ventrolateral and dorsolateral pathway. So they actually end up here in the prefrontal cortex, the signal coming from the auditory cortex. So the researchers that developed the first, Dorman and colleagues that developed the first treatment, they actually thought, okay, so we're going to put the training electrodes in the regions that are most likely to pick up the activity coming from the auditory cortex. So when training EEG neurofeedback for tinnitus, we use these frontal central sites here. I hope it makes sense. I can't see you, so I'm basically talking into a room, which is anyway. So let's move on. Let's look at some of the studies. Basically, the first study that was done based on this neuronal signature of tinnitus was done by Dorman and colleagues, part of Dorman's PhD, back in 2007. Basically, Dorman had 3 groups, 21 participants, not a large sample, you could say. These 3 groups, in the one group did alpha training only over these frontal central regions. One group did delta training, 3 to 4 hertz, and the third group did alpha delta ratio training. Now, neurofeedback in general was compared to a frequency discrimination training. This group was not part of the same trial. There was data taken from a previous study, which one has to consider when, of course, talking about whether the sample characteristics were similar. It wasn't a so-called a randomized control trial where participants were divided into one of these 2 groups randomly. It was 2 different studies, but they pulled them together to compare the effects of neurofeedback with frequency discrimination training, which is basically learning to discriminate a sound sitting in a sound booth. That's what frequency discrimination training is. Okay, so what did they do, Dorman and colleagues? They did 10 sessions of neurofeedbacks over 4 weeks, and as their outcome measures, they had the tinnitus questionnaire, that is basically the distressing aspect of tinnitus, how much is that reduced with the training. And then for the loudness, the intensity, they took a 1000 hertz tone, and basically they enhanced or reduced the decibel around that 1000 hertz to match the intensity of tinnitus before and after neurofeedback. The results of the trial was here we have the frequency discrimination training, and the frequency discrimination training participants were assessed twice before the intervention. That is, whoops, where's my pointer there? So here, this is immediately before start of the intervention. This here is the tinnitus distress score. And as we can see from this slide here, there is a marked reduction in tinnitus distress when applying neurofeedback compared to doing this frequency discrimination training. And the reduction happened in the intervention period, whereas after the intervention period and in the 3 months follow-up, there seemed to be a kind of a steady response, you could say, or no further development for the neurofeedback group. Looking at the intensity, what they found was that it was the participants who could influence both the alpha here, it's called tau, it's basically just auditory alpha, that's called tau. Those that could influence both frequency bands simultaneously had the largest reduction in intensity. Moreover, for those that report those that had no change in the alpha delta frequency, that is no change, no actual physical change, they still reported a 20% reduction in intensity. And the authors here said, well, that could be indicative of a placebo response, because with no physiological change and still a change in intensity points to a placebo response there. All right, so 4 years later, some researchers in Italy decided to replicate the study completely. They used the same training sites, they used the same frequency bands. When I say training sites, I mean the same electrode positions. They had 12 sessions of neurofeedback, not 10. They used a different questionnaire, the tinnitus handicap inventory that we also use in our study to measure distress. And they used a visual analog scale. I don't know if you're aware of that, but a visual analog scale basically just means having something where you have a slide on and you can say, how loud is my tinnitus, going from maybe from 0 here to 10 over here, and then I put the slider somewhere where I think where my tinnitus is at the moment. So those were the two outcome measures they had in their study, and I couldn't fit their output neatly, into this little whiteboard here, but I think I can convey to you the main point. The main point of their trial was, as in Dorman and colleagues, a significant response, a positive response of the treatment, neurofeedback treatment, between the baseline measure before the therapy and immediately after the therapy. And what we then see after this training response is a plateauing of the distress level and intensity level. That is, after training, nothing more happened, but during training, definitely a significant improvement in both the tinnitus distress and in the intensity measure. Very positive. I should say that Crocetti and colleagues, they only used the alpha delta ratio training because Dorman and colleagues had shown that influencing both frequency bands simultaneously was most effective in reducing the intensity of tinnitus. So since then, the study by Crosetti and the one I'm going to show you next, and our study have all used alpha delta ratio training. That is the simultaneous enhancement of alpha and decrease in delta is what we aim at. And for those not versed in neurofeedback, I'll show you a little bit later how that happens. Right. Yes, the next slide. Yep, that is our friends, Günzensperger and colleagues from the same research lab as Dorman. They basically just completed the third study using this alpha delta ratio training protocol. Basically what they did was they used an alpha peak frequency instead of the standard 8 to 12 hertz frequency band. So basically what they did was they took someone's alpha peak frequency, for example, if that is 9, then they took a band around that of 2 hertz to have a frequency band going from 7 till 11. So if my peak was 9, the frequency band trained would be from 7 till 11. If my frequency peak was 11, it would be from 9 till 13, etc. So that was the difference. They tried to individualize the alpha frequency band. Yes, so Günzensperger and colleagues, they did 15 sessions. They only had 1 session a week. They used the same electrode positions again, like the other studies. They also used the tinnitus handicap inventory for the distress measure, and for the loudness, they used, well, basically asked them from a scale from 1 to 100, how loud is your tinnitus? So that's the third way of measuring loudness in 3 studies, which also shows that there is no consensus, no easy way to get a loudness measure in tinnitus. And people or research groups, including us, try to assess that in different ways. Right, so again, same pattern as the other studies. Here's the tinnitus handicap inventory score. We see a marked reduction, a significant reduction from the baseline to after the intervention, which remains stable at follow-up. And for the loudness measure, interestingly, we had a marked reduction, a significant reduction from the baseline till immediately after the intervention, when it was rated immediately after the intervention, but that somehow bounced back to the baseline level, which is not good news because, like I said earlier, the one thing that people with tinnitus want is a reduction in the, well, at least perceived loudness, more so than in the, you could say, in the psychological dimension of tinnitus. So basically, yeah, if we sum up this, go here. We sum up the results here. Basically, they do show promise, and they do show reduction in both distress and in loudness that in Günzensperger study returned to baseline, but it's promising enough. But there were no control groups in either of the studies. Dorman did have this frequency discrimination training group, but was not part of the same study, so you couldn't make a direct comparison between that training and neurofeedback, and also frequency discrimination training is not something that is considered a treatment as usual, or TAU. So therefore, we do not know the extent to which other factors than the actual neurofeedback training of the alpha delta frequency band had on the results. Why is that a problem? Well, it's not really a problem, because all therapies that involves people and interaction between a therapist and a client, whether it be neurofeedback or psychotherapy, they have some components to them that are common to all therapies. Now, if we look at someone entering a therapeutic process, if you look at their improvement, let's say someone enters psychotherapy and remains it for 6 months. You ask the person before, how distressed are you at the moment in your life, and say 100 on a scale from 1 to 100, or maybe 80, and then you ask them after the therapy, how distressed are you now? You say, well, 20, I feel a lot better. A lot of factors play into this improvement of a score of 60. This is just a thought of example, but just to show that the actual technique used in the therapy might account for only 15% of the improvement. If someone came in with a depression 6 months later, he might have had a spontaneous remission rather than the specific technique. Maybe this spontaneous remission had a lot to do with the improvement. So just the passage of time really had an effect. Common factors entering a therapeutic alliance is in and itself very healing. So it doesn't really matter what I do with someone, as long as they come to my office, sit down and talk to me about their problems, they will improve. Then there is this expectancy effect. So that is also quite a significant effect. That is, it's also called the placebo effect. And we all, I guess, know about the placebo effect, that if I expect something good will come out of my therapy, that in itself is enough. I take a white pill with an inactive substance, and I rate my depression after having taken it for 3 months, and I've just eaten basically chalk or something inactive, an inactive component, I will still report feeling better. That is the placebo response. But we also know in the placebo response is that, for example, in medicine, the placebo response is greater if someone takes a blue pill compared to taking a white pill. So that means that actually a placebo response is not just a placebo response, it is also to do with the content, the feel about it, that also decides the magnitude of the placebo response. And in neurofeedback, there is this ongoing discussion about whether the effects that is observed in neurofeedback are just a result of placebo. In fact, some call it a super placebo. And basically what is argued is that this high-tech environment, this neuro lingo that is spoken by the neurofeedback practitioner, basically induces higher expectations that are normally seen in other therapies. And if you don't have, with no control group, you simply cannot know the extent to which this placebo effect played a role in the studies that we've just reviewed. I hope you follow me. Yeah.
Yeah, it's very good. Thank you.
Okay, good. So you could say, in sum, the studies before ours were promising. They were basically showing an effect of the neurofeedback treatment. But the question is, this effect we got, or they got, was that the result of the actual training, the physical manipulation of alpha and delta frequency or oscillatory activity, or was it just a result of them coming to do an experiment, being part of an experiment, doing neurofeedback? The question that I thought about is, and some other people have said that, does it matter that it is a placebo response as long as it works? People feel better about themselves. They feel better about their tinnitus. And that was also, well, I can come back to that, but my personal experience is that it was very beneficial for the people doing neurofeedback. So if it is a placebo response, you could say, so what? But let's talk about that later. Now, we should come to why we did our study. Basically, I hope by now that should be a little clearer that looking at these studies, looking at the promise and seeing, well, there might be something here. There's definitely something worth exploring. But we need to be able to disentangle specific effects. That is, okay, if we talk about, again, going to the pill example, specific effect of an antidepressant would be the actual components in the pill that facilitates neural transmission in my brain. So that would be the specificity of the antidepressant pill, what it actually does in my brain. So I take the pill, it does something. And the same if you go to this neurofeedback area. The specific effect is the alpha delta training. That is what is actually done in my brain. So we wanted to basically be able to disentangle that specific effect from the non-specific effects I showed you before. And the way to do that, we thought there might be other ways to do it, but the way to do that would be to compare the alpha delta ratio training protocol to a neurofeedback training that is at least theoretically unrelated to tinnitus. And we opted to go with a group that trained beta and theta ratio. Now, or it was beta theta ratio neurofeedback training group. All things between the two groups were identical, everything, apart from the targeted frequency bands in training. Is that an optimal solution? Again, there will be various opinions on this, depending on who you ask and when you ask them. But we opted to go for this solution because we, for ethical reasons, were not allowed to do sham feedback, neurofeedback. That is, well, basically showing feedback that is unrelated to the neuronal activity. So we opted to go for an active comparison group. But the advantage is, by doing that, we have all the common factors. All factors are are the same, bar the trained frequency bands. Now, because of the debate in the community about neurofeedback being a super placebo, we also included a third group. And this third group was what I now call a minimal treatment intervention group. Now, what they did was they met with a counselor twice. They had 4 telephone follow-ups in a 4-week intervention period. They had the first session in which we used psychoeducation, told them what you would do in cognitive behavioral therapy. At the first session, you would tell people about what is tinnitus, what causes distress, what can you do yourself to get better. Then we asked them to do some attention and some relaxation exercises at home for 4 weeks. Well, for 2 weeks in the 4 weeks. And we also asked them to complete a diary, which in other chronic condition studies have turned out to be quite beneficial. For example, in chronic pain, using a diary to keep track of your symptoms actually has shown benefit. So this third group, what you could say is basically what we do in that group is we also have the therapeutic relationship. We also have expectations. We can, well, basically not influence it, but people will have expectations when they come. They are presented about the rationale for the treatment. And you also have these other factors that are common to the neurofeedback condition. So now it should become clear. Sorry, maybe I'm rambling a bit. I don't know. We'll see. Anyway, so our 2 main scenarios that we wanted to investigate was whether, as I call here scenario 1, we wanted to investigate whether the treatment effect was specific to the alpha-delta ratio training. So that is, if there is what I call specificity for alpha-delta neurofeedback, then the improvement here, this is the alpha-delta group, should be greater or heavier than in the beta-theta group when you compare the results after training. The second scenario is that it is non-specific effects that drive the improvement seen in the tinnitus trials, or at least in the trials using this protocol. And if that is the case, we would have no difference between the improvement in the groups. That is, if there's no specificity of alpha delta, no difference between the groups. Our bonus is the kind of ability to elucidate whether neurofeedback is in fact a super placebo. And when I say that, it means that if we compare the results or the improvement in the beta theta group, which is supposedly or hypothetically an inactive treatment for tinnitus, if the improvement in that group is greater than in the minimal treatment intervention, then we have, well, basically we have 2 inactive treatments, right? 2 treatments that are supposedly not working as well, or sorry, they work equally well in theory. But if we have a difference in outcome between the 2, it would mean that we have a bigger placebo response in one of the groups. I hope it makes sense. So just 2 slides here on the timeline, just to show you that you know what went into the trial. Basically, we had a pre-screening process. That means we had all participants registering for the trial via our website. They completed some pre-screening questionnaires designed to tap into these inclusion and exclusion criteria. So basically, for example, if someone said, yes, I've had tinnitus for less than 6 months, they were excluded from the trial. If they had a tinnitus handicap that was only none to mild, they were also excluded from the trial. I guess my main point here is the inclusion and exclusion criteria for our participants are quite similar to those seen in other tinnitus studies. So our population is quite characteristic of other trials. Of the 190 participants that were pre-screened, we ended up randomizing to one of the three conditions, 103 participants, so 34 for the alpha-delta neurofeedback, 33 for the beta-theta neurofeedback, and 36 in the diary control. And they were all, I'll get back to that. Anyway, so here we have what I call included in the intent to treat population. That is our main analysis. That's just to show that 90 participants completed both the baseline questionnaire and the what we call the post-intervention questionnaire. That is the questionnaire or the assessment they get immediately after the intervention has finished. Out of the 90 people who did, oh, and now Siri starts, great. Sometimes I get scared about Siri, Google. So out of the 90, sorry about that, out of the 90 participants who completed our questionnaires in this intent to treat population, 88 of them actually completed the training protocol. So that was a good number. So how did we get from the start to finish? Basically, people, we call that time zero because that was before we started the assessments. People underwent a telephone interview. They underwent what we call a psychophysiological assessment at our department. That is, they came in, we talked to them, they completed the informed consent, and then they did some attention tests that we use in an unrelated, well, a related, but to this neurofeedback trial, unrelated study. Then they went for an audiological exam at a university clinic in Marburg. And only then were they randomized to one of these three conditions. And then basically they did the neurofeedback or they did their minimal treatment intervention. I'm going to talk a little bit about the neurofeedback training in a minute, how that was set up for the participants. But basically they did 10 trainings over 4 weeks. And we used as the primary outcome measures the tinnitus handicap inventory and a quite recent scale called the tinnitus magnitude index. So instead of having a loudness measure only, we decided to go for this tinnitus magnitude index, which is basically a measure that is not confounded by someone's emotional reaction to tinnitus. That is, we ask people 3 questions basically. One, going on the awareness of tinnitus. How aware has the person been of tinnitus over the last week, percentage-wise? How loud was your tinnitus? And that is a 1 to 100 scale or a rating. And how severe was your tinnitus in the last week? And that is no tinnitus and the worst tinnitus you can imagine are the 2 anchor points. So no tinnitus, 0, worst tinnitus ever imaginable, 100. So these 3 questions combined give us a measure of intrusiveness, that is awareness, loudness, and severity combined. And our trial sequence, we used the same software, the same training material as did Dorman and Crosetti. So basically, if we start from the top, we did 10 sessions of neurofeedback over 4 weeks. The first 5 sessions, we had 4 training blocks in each session. A training block basically consists of 10 individual training runs, and one training run consists of a baseline here, blue screen, pause for 10 seconds. In this 10 seconds, a reference ratio was calculated. You might be able to just see it here if you move close enough. There is a black reference line here and the triangular pointing upwards, indicating that you want the fish to move upwards. So what happens was, in this baseline period, this reference line was calculated, or the alpha delta ratio was calculated for each individual trial. And then the fish came in and it started bobbing around this reference line, which is of course the average. And our participants were told, your task is to try to get the fish to swim upwards using any mental strategy of your own preference. And these instructions were similar to the instructions given in the prior studies. So basically, of course, we explained to the participants what they saw and what they had to do, and then they were told, try using mental states to influence the movement of the fish. So the reward was given in the shape of a sun. I should have put that in. But for example, if the fish was above, you can't see, there is a reward line up here somewhere. That was an individual threshold that the therapist could adjust. And if the fish came above this reward threshold, they were given a sun indicating that they had done exceptionally well in this individual trial run. So 10 sessions, first 5 sessions, 4 training blocks, and from session 6 to 10, 5 training blocks. In the last training block here, from session 6 to 10, we used transfer trials, and the transfer trial was basically, they didn't have the feedback in some of these trials here. They didn't have the feedback from the fish, but they were told to use the same strategy and transfer their mental activity to an image of their choosing. So they brought with them an image. For example, someone brought an image of a holiday scene, and they would sit there with the holiday scene. And when the fish did not come, they were told, instructed to look at the photo and try to emulate or achieve the same mental state as when the fish was present. So basically the idea was they could take it home and do some training at home, trying to get into the same mental state as when doing neurofeedback with us. Right. So to the results. Oh, time is running, Jesus. Right. So to the results. I cannot show you the actual data because they haven't been published yet, but I'll show you improvements in percentage, and that should become clear in a minute. Let's look at just the sample size of these 90 participants who were included in the analysis. The oldest person was 78, quite impressive, and the youngest 18, and they average baseline tinnitus handicap inventory score was 37. So looking at the results, our alpha delta group had an improvement in their tinnitus handicap inventory. That is, they had a reduction in the score, that is an improvement of 36%, compared to 25% in the beta theta group, compared to 20% in the minimal treatment intervention. So it's actually in the expected direction. For the tinnitus magnitude index, that is this intrusiveness measure, that's quite interesting because there was a marked reduction in the two neurofeedback groups, but not for the minimal treatment intervention group. So basically, looking at it from a statistical point of view, we would have a significant, what we call a significant main effect of time. That is, participants, irrespective of group for the tinnitus handicap inventory, would improve significantly. And also the same goes for the tinnitus magnitude index. The interesting part in science is, of course, is the difference between the groups significant. And as you remember from this scale I showed before, specificity would require a significant difference between these two groups, and we'll get to that, but basically our analysis, our statistical model did not find that the two groups differed from each other significantly, although it is in the expected direction. The significant difference was between the alpha delta training group and the minimal intervention group. There was a significant difference between these two groups, but not between the training groups. And interestingly as well, I think, if you talk about the bonus question, there was no significant difference between the beta theta group and the minimal treatment intervention group, indicating that there was not a super placebo response associated with neurofeedback, at least for the psychological dimension. Because if you look at the magnitude dimension, that's interesting. My own take on this, and I'm gonna ask for your take, but my own take on this is someone doing neurofeedback expect something to happen with the loudness, maybe, or maybe it actually works, but there's no discrimination between the two groups. But I come in, I put electrodes on, and I expect to work on the loudness, and maybe there is more of a placebo response there than with the other measure here, because of this big gap between the neurofeedback groups and the well, let's call it control group. But yeah, interesting what you think. So in sum, like I just said, if you conclude in a strict scientific sense, it does not matter what you train. Whether you train alpha delta, beta theta, a person will report improvement. But one thing to have in mind here is that the trend is in the expected direction. That is, although not significant, the alpha delta treatment was somewhat more effective in improving tinnitus characteristics. So what is interesting is, of course, also how does neurofeedback compare to, for example, cognitive behavioral therapy, which is presently the recommended treatment for tinnitus distress. If you look at the THI score alone, 30% of the participants in the neurofeedback alpha delta group had a reduction on the THI score of 14 or more points. Now, that is called a clinical significant improvement. In terms of, that is basically, that is an improvement that can be felt. So 30% of the participants in this group basically had a response that was meaningful to them. And if you compare that to cognitive behavioral therapy, this clinical significant improvement for tinnitus is between 30 and 50%. So neurofeedback is as effective or as good as CBT. At least you could say it's comparable. It's comparable in effect, right? So the good points. There's an effectiveness of neurofeedback, alpha delta, which is comparable to cognitive behavioral therapy. If you look at the literature, in cognitive behavioral therapy, tinnitus respondents normally don't report a reduced loudness or intrusiveness percept. However, again, strictly scientifically, there was no specificity here for the alpha delta training, but our sample size was inadequate. Although we had a lot of participants, we would have required a few more participants to be able to conclude this with a greater certainty. So that is probably what we take away from this is we could have done with a few more participants. What is a few more? Well, looking at the effect of the treatment, I would actually estimate that we would need not 98 participants like we originally calculated with, but we would probably need more in the range of a couple of hundred participants to be able to detect a difference between the groups. But I still think it's encouraging. I still think these are encouraging results, and I think that there is something to work with here. Now, before the question or comments, I just had a couple of reflections, and one goes on, is it possible to get at the auditory cortex with neurofeedback, maybe newer ways? Loretta, I don't know, neurofeedback. There are probably people for whom it works better than others. Whether there is an actual neural signature in tinnitus is debatable. We decided to stick with one model because we agree with some of our colleagues in the field that we need to test specific models and not just go from one to the next whim and say, okay, now we found a new discovery, so we chase that. We need to stick to what we know or findings, and then work from there, build from there. And if it turns out that there is nothing in it, we need to move to the next thing. But as I said, there is a debate whether you can actually have or whether there is a neural signature in tinnitus. The strongest indicator is that there are two recent studies show slow oscillations in the delta theta frequency bands over the frontal temporal regions. So maybe less so associated with alpha and more so with slower frequencies in the frontal temporal regions. So still many questions remain unanswered, and now I think I've used up my talk time. And I have some references. Just if anyone is interested, I can maybe send the reference list to Marianne, or you can write to me, and I can send them to you if you're interested in knowing more. Anyway, I guess that was the main message. I hope it wasn't too confusing. Of course, I couldn't see you guys too well, so it's a little bit difficult when you just talk into the room, but I hope you got something from it.
Thank you very much, Martin. I felt that was very clearly set out, something that's actually quite confusing. You actually clarified things that I think is hard to explain. So you did in my mind, you did a very good job of simplifying the complicated. So thanks for that.
Thank you.
So it might be worth unsharing your screen. So
Oh, yes, of course.
Then see everybody,
Yes.
and people might be able to look at you and ask questions and things.
Right.
Yeah, there we go. So there were a couple of questions that came up on the chat.
Yep.
Do people have, so why don't I read a couple of them just so that, and then we can, I know people will have questions, you can put your hand up and unmute and just ask them. So the first, were there age differences found in your results?
Age differences?
Yeah.
So differences between, well, basically the what we did to ensure an equal, you could say, distribution, so that we didn't have a majority of older people in one group, was we used a stratification procedure, meaning that every time a person was randomized to one of our 3 groups, they were randomized based on their an age category, how much distress they had, or whether they were male or female. So we had equal distribution there, and therefore my main focus has not been on looking at differences, predictors of response yet. That is for a subsequent study. Someone else who comes in and looks at all the data and start looking at predictors, because so the short answer is I cannot say whether there's an age response yet. I cannot say the extent to which a person's expectations influence the results. We also measured that. We also measured things like how do you feel about the person doing the training? How is your relationship with that person? Do you understand the rationale for the treatment? All many variables, or many questions were asked, so that we hope that in time we are able to actually, as I say, look at what was actually more decisive for a treatment response. So I can't say that yet.
Yeah. Okay. Very good. And how does the degree of hearing loss affect the neurofeedback success?
Same answer. That is also something that we'll have to look at. I'm sorry, I can't answer these things yet. They will have to wait. We are still in the, I wouldn't say early stages, because I'm in the, of course, the late stage of my project. But I haven't had that as my main focus. My main research question was on differences between the groups and the specificity versus non-specific effects of the treatment. Unfortunately, well, fortunately, but unfortunately, I can't say that yet.
Okay, very good. And there's some neurofeedback questions. So
Right.
Mark, did you want to actually ask your question directly, or did you want me to read it?
Either way, I don't mind asking. Hi, Martin.
Hi.
I was just wondering some of the specifics about the training. When you've got training those 4 sites, were you using a 4-channel amplifier and training all sites simultaneously? As in, were they summed into one variable?
Yes, they were.
Okay. And and where were your references? Were you using ear references, like linked ear?
We used we had the reference. The setup was, I'm thinking because it's 6 months now. No, sure. The reference was right mastoid.
Yep.
Yeah, and then we had well, that was mainly for artifacts. We had electro sensors around the eyes, and also 200 trapezius. So ground left, reference, right.
Yep.
Yeah.
Okay. Cool. So even the left, sites F3, for example, was referenced to the right mastoid.
Yes, it was.
Mm.
Yes,
Okay.
it was.
And so where did you put all the electrodes? Where were they actually placed on the?
Yeah. As I said, we can't, this bloody auditory but the auditory cortex is kind of here inside the temporal lobe. So we put them well, what here.
You have the perfect
This
head
would
for
be
doing
this would be FC1, FC2 approximately, and F3, F4. So these ventral, lateral, and dorsolateral streams, they come from the auditory cortex and go this way. I don't think it's ideal, I must admit. I think there must be a better way to get to the auditory cortex activity. But interestingly enough, and I didn't take that into the presentation, but my friends in Zurich, Günzensberger, that did the third study, they actually tried using S-Loretta training. So they tried to target auditory cortex activity more directly with alpha delta training. But that wasn't, again, in science, significantly better than doing EEG neurofeedback using the, I just call them frontal central sites here. So there was no difference. But still, well, similar comparable results.
Am I right in understanding you did about 50 training sessions if I calculated all your slide
Yeah,
up?
I know that was probably a little bit. Each participant did 10 training sessions. And that is also something you have to take into account, because if you talk to practitioners, I don't know how many of you are practitioners.
Yeah.
10 training sessions, how much is that? Who did 15? Günzensberger. They did 15, but they did it over 15 weeks, so it wasn't very intensive. But I guess the challenge in this field is that, I mean, I spent basically, me and some of my colleagues, we spent almost a year just collecting, as I say, collecting data, just doing the training, a year, and it isn't many studies, research studies, that have the luxury of being able to say, well, we're just going to dedicate a year and a half to doing this. And therefore you end up with these small sample sizes, and you also end up with a compromise in number of training sessions. Yeah, your take on it is probably you need 40 or 30 or but the thing that, and I would think that could be a next step. Take some of the responders after 10 sessions and say, okay, so these guys have a good response, and maybe continue with the responders. I don't know, that could be a future solution. I still think, I don't know what you think. I think the results are encouraging here, and also some that I would say justify further investigation, now that we can say that it is more effective than actually doing this minimal treatment intervention. And it is actually also, I would say, it's not significant, but it's substantially better than doing beta theta training. I don't know, do we have practitioners amongst us who have an idea on what we're actually doing when we do beta theta training?
Yeah.
Yeah, I'm not sure.
That would be interesting.
Yeah, I get what.
Yeah.
Sorry. I get what you're saying about the number of sessions. I mean, I think most practitioners would think you'd want to do at least 2 to 3 sessions a week over a, like you said, 30 or 40 sessions. And I think there's research by Siegfried Hoffmann that shows that often at sessions 20 to 40, they get an even greater, or this was with ADHD, got a greater improvement in the second 20 than the first 20 sessions.
Yes. Yes, I've seen, and maybe that's the rationale that we use, not maybe, but that is used in neurofeedback, is that there seems to be a plateau after 10, 12 sessions.
Yeah.
The effect plateaus, and then you have people who argue that, well, if you continue, then you get another incline in the effect after maybe 20 something sessions again. So we might not have seen the full response. We have seen maybe an initial response here, but maybe not a full response.
And possibly, but why in that study prior to yours, there was a decline back towards baseline after the sessions were stopped. I was just thinking maybe not enough sessions were done to maintain an ongoing effect. Yeah.
That was in the loudness measure.
Not often enough, because 1 a week in a lot of people isn't really doesn't sustain the gains.
Mm-hmm.
You really need twice a week. Yeah.
Yeah.
And have you used this not just in your research, but also clinically with clients? Because maybe you've done 20, 40 sessions if you've used it in practice and seen the ongoing effect of the treatment, like just, this is outside research, I guess, just in your own experience more, but.
You know, I came to this peculiar field 3 years ago. I did the training. I did some training to prepare myself for it, but I haven't worked as a practitioner. And this is also something that is interesting when you look at these results. It wasn't just me doing the neurofeedback training. I did about 30 of the participants, 35. The rest was actually done by people who I trained, students, my colleague. And what can be said about that? Well, two things, obviously. One thing is, they were novices, and I was kind of also a bit of, well, I was a novice in neurofeedback training. That can be an advantage in the scientific sense, in that we are naive. Whereas someone like an experienced practitioner might come in, we might hire them for the job, and they come in with their set of expectations, and we all have expectations. We can't take them out of us, regardless. But maybe the advantage was this naivety. What? Yeah. But maybe the disadvantage was that we could have gotten a greater effect, maybe, if we had been more knowledgeable about good strategies to use for the training. Do you know what I mean? So we could have guided the participants better, maybe, with greater knowledge. I don't know. So I haven't used it. That was the answer. Sorry, I haven't used it myself for 30 or 40 sessions. And in my opinion, I also think it's a little bit premature to go out and advertise it as a treatment for tinnitus yet. I would probably try with someone if you were contemplating it. I would probably try it with someone, but then not. I don't know. Yep. Sorry.
Yeah. And do we have any other questions amongst?
Yes, I just wanted to ask if, and it might be a similar answer to the other questions, but was there a comparison about how well the participants did with the fish in terms of the effect of the training?
What I did not, and thank you for the question, because what I did not say yet was I am actually still in the process of analyzing the EEG data. And that is obviously quite an important parameter. I've completely forgot that, because it's in the process right now. So what we want to do is obviously very important, and also a criteria for publication is we need to be able to show some kind. We need to map the EEG data to the behavioral data. But what I can, from the behavioral perspective, for me, if I should explain what happens, I think that the people doing alpha delta training, they found it easier to get the fish to behave, so to speak, than the people doing beta theta training. And I don't know, you guys who do neurofeedback, what your take on it is, but I think achieving this relaxed this relaxed, almost introspective little bit state in the alpha delta training was conducive for people's health, mental health, compared to the beta theta training, where I found people struggling more, finding a good strategy for getting this fish to behave. Yeah. But behavioral data will correlate that with the EEG data to see. Yeah, hopefully there is an association.
What software was it that you used with the fish?
Yes, we used the the Thera, what's it called in German? Theraprax from Neurocon. I don't know if any of you are familiar with that. It's a German brand that was used by Dorman, and also I think Cossetti also used that. And we used exactly the same one as Dorman did. The same setup, the same stimulus for feedback training signal, etc.
Yep, very good. Is there any other questions amongst the group? Any feedback or reflections or anything you want to share with Martin about what you got out of it? Or
Can I just want to make a comment about whether or not neurofeedback was placebo, which I thought was a very interesting question from Martin. I get what's being said is that if people come in and see an impressive array of equipment and some monitors set up, they get a feeling that's going to do something for them. I'm drawn back to the initial research from the 60s that was done with cats, and proving that you could train a cat. It's purely operant conditioning of the EEG. So the cats would increase the sensory motor rhythm when they were rewarded with either milk or chicken soup for doing so. And then it was accidentally discovered after that the cats were therefore more resistant to having seizure activity. So that's not a placebo, I think. A cat isn't having it done with an expectation of an improvement for itself.
I agree. That is a remarkable research by Sturman and the colleagues there. Yeah. However, it is the research that people always mention with neurofeedback. I'm not for nor against. I came into this with an open mind, but I've also noticed that it's always the Sturman cats that is mentioned, and it was I think it was. So I think it's good that we try to dig into it a bit more, because otherwise practitioners such as yourselves will always be met with skepticism, because it has not been validated. And if you look at review studies, the problem is they continually call for the type of study we did, even maybe other studies using sham placebo, because we just it just needs that stamp of approval, I guess. Unless you will, until then, you will always be met with the criticism.
Oh, it's true. I mean, I think sham feedback's really not ethical. If you know of something that works, to not give it to someone is, in my opinion, is unethical. And any practitioner will have their own experiences. Like for me, I've done a lot of work with the autistic spectrum. I've seen non-verbal children start to speak. I've seen people with epilepsy completely stop having seizures. And for me, that's not, you couldn't put something like that down to a placebo.
No.
The research, yes.
Yeah. And there is actually a group, sorry, there is just on the epilepsy, there is a group that is going to do some research now on the expectancy, try to influence people's expectations, people with epilepsy prior to treatment. So that's going to be interesting when they come out with their results to see whether, because that obviously you can't fake epilepsy, so so there shouldn't be an influence of expectancy on that. Anyway, sorry. Yes.
I was going to ask if the EEG results show that there is a change, there is an effect, would that be still at all considered placebo? You know, like, could that be placebo also? You know.
I don't know what you. Any of you other guys, your take on it. There is, I can't give you the reference on the top of my head, but there is some evidence that I've read that it's easy to say when I can't give you the reference, but that alpha is actually quite vulnerable to placebo effect, alpha activity. I would have to find of course, the source for this. For example, one thing that was highlighted to be by one of my colleagues in a discussion a couple of weeks ago was that maybe the reason why people with tinnitus have a lower alpha, or were shown to have a lower alpha power over the temporal cortices when it was measured, was that they came in to do a resting state EEG for the first time. It was the first time they ever got electrodes on their heads, so they were maybe anxious, affecting their alpha amplitude, overall alpha amplitude. Then you have a control group, people who are maybe more. I also had that with our control group. People just basically are used to coming in to do research. I've done this before. You know, I've had electrodes on my head before. So they are more relaxed in that environment. That's someone coming in for a tinnitus trial, and that might affect somehow the oscillatory activity at that given time. Whether I've done 10 EEG measurements or I've only done this for the first time. So could it be could the EEG data also be placebo? I don't know. It could be affected by something other than the training, probably. I think, anyway.
Yep.
I notice we're right at time. So is there any other questions or reflections? Anything you wanted to share? Anyone wanted to speak?
Just share, Martin, and also Marianne, for organising it. That has been super interesting, and I think, as Marianne said as well, put in such a way that it's easy to step through and see how it's progressing in terms of the data itself and the outcomes. And as you said, you know, any scientific experiment leads to sometimes more questions than it answers. But it's part of the journey. So I appreciate you sharing it with us today.
Thank you. And I appreciate that. And I would also say that for me, this is not the end of the journey. As I said, I myself, I have tinnitus, so it's also a personal quest for me. And I definitely think that we have something here that we can build on. So yeah, unfortunately, it's not the magic bullet yet, but we are probably getting steps closer all the time.
Very good. Well, thank you very much, Martin, for your time and your expertise and what you put into sharing with us. I really, really appreciate it. I think it was really, really good.
Thank you.
Yeah.
And thank you all for taking the time to be there and listen. I appreciate that.
Yeah, and I'll send out your details if you like to people if they want to email you or something.
Yes.
Or...
Yes, definitely.
Okay.
Please do so. I can also send, if one is interested in an article or two, I might be able to send that as well your way. So
yes, I can see some nods going on, so I think that sounds good. Yeah, great, and I'll send that out. So thanks again for your time.
No, thank you, and enjoy your evening.
Yes, enjoy your day.
Thank you.
Thank you. Thanks, Martin.
Thank you.
Thanks. Bye-bye.
Bye.